Okay, so let's set the scene. You're in a clinic, a patient is hooked up to a monitor, and suddenly it starts flashing. The numbers are sky high, a blood pressure reading so scary it feels like a ticking clock. Right there, in that moment, a massive decision has to be made. And that choice will send the patient down one of two very, very different paths. Today, we're decoding that exact high-pressure situation. When you see a number like this on the screen, we're talking a systolic over 180 or a diastolic over 120. Yeah, that's what's known as a hypertensive crisis. And just seeing it triggers this immediate gut reaction in pretty much everyone, right? The clinician, the patient, you just feel this overwhelming urge to do something about it and do it fast.
And that instinct, it makes perfect sense, doesn't it? The pressure is way too high, so the solution has to be to bring it down. And bring it down now, get it back into a normal range. It just feels like the most obvious, the most logical, and frankly, the safest thing you could possibly do.
Well, this is one of those moments where medicine gets really counterintuitive. Because what if I told you that slamming on the brakes and dropping that pressure too fast could actually be more dangerous than the high number itself? What if the right move in most of these cases is actually to be patient? And that's the central tension we're going to dig into today. So, before anyone even thinks about reaching for a medication, there is one single question that has to be answered, and it changes absolutely everything. It is the fork in the road. The question is this ridiculously high blood pressure right now actively causing damage to the body's major organs? The answer to that simple yes or no question dictates the entire game plan. So here they are, those two distinct paths laid out for us. On the left, we've got what's called a hypertensive urgency. The key phrase here is no end organ damage. This can often be handled in an outpatient setting, with oral meds, and the goal is to bring that pressure down slowly. We're talking hours, sometimes even days. But on the right, that's a hypertensive emergency. Here, there is active ongoing organ damage. This means an ICU admission, IV medications, and a faster but still very controlled reduction in pressure. Two totally different worlds, and it all hinges on that one factor.
All right, so let's head down that first path, hypertensive urgency. And honestly, this is the one you're going to see a lot more often. You've got that scary high number on the monitor, but the patient, they feel okay, maybe a slight headache, and a quick checkup shows no signs of any acute damage. The prescription here is patience.
So you might be thinking, well, why not just give it an IV and fix it quick, get it over with? What's the actual harm? And that's a totally fair question. The answer really comes down to how the body adapts to things. When a person has had chronically high blood pressure for a long time, their body, and especially their brain, it gets used to that new normal. Yeah, see, there's this thing called autoregulation. Over time, the blood vessels inside the brain have recalibrated. They now expect that higher pressure to get enough blood and oxygen. So if you suddenly tank the pressure, you can shock the whole system. Those vessels can't adjust fast enough, and the result? You could cause a stroke, not from a clot, but from not enough blood flow. It's the same idea for the heart and kidneys. A sudden drop in their blood supply can trigger a heart attack or acute kidney failure. So slow and steady is the name of the game here. Okay, now let's switch gears and talk about that other path. This is a true, no kidding, life-threatening medical emergency. Here, the high blood pressure isn't just a number, it's an active force, and it's literally destroying vital organs as we speak. So in this case, yes, we need to act fast. But fast does not mean uncontrolled. So when we say end organ damage, what are we actually talking about? Well, it mainly comes down to these three critical systems. First, the central nervous system, your brain. Second, the cardiovascular system, that's your heart and your major blood vessels. And third, the renal system, which is your kidneys. These are the main battlegrounds where the damage is happening. And this isn't some abstract concept, right? These are real, tangible signs you can see and measure. For the brain, we're talking about confusion, a crushing headache, maybe even seizures. For the heart, it's that classic chest pain, fluid backing up into the lungs, or clear signs of a heart attack on an EKG. And for the kidneys, it shows up in the lab work as an acute injury, with creatinine levels starting to climb. These are the red flags that scream emergency. Now, this is so important. Even in a true emergency, the goal is not to slam the blood pressure back down to normal. The goal is a controlled reduction. The target is to lower the overall pressure, what we call the mean arterial pressure, by just about 10 to 20% in that first critical hour. That's enough to stop the ongoing damage without crashing the system and causing the very problems we're trying to prevent. In a hypertensive emergency, things get very specific. It's not a one-size-fits-all approach. The kind of organ damage that's happening dictates the exact medications you use. It's like having a specialist's playbook for each unique type of crisis.
Okay, so let's take aortic dissection, a tear in the body's biggest artery. The goal here isn't just to lower pressure, but to reduce the physical stress that's literally tearing the vessel apart. To do that, you have to give a beta blocker first. That slows the heart rate down. Only then do you give a vasodilator to widen the blood vessels. That order is absolutely critical.
And I know we just said it, but it is so important, it's worth saying again. If you give that vessel-widening drug first, the heart will instinctively try to compensate by beating faster and harder. That dramatically increases the tearing force on that already damaged artery. Getting this sequence right can literally be the difference between life and death. Now, what if the crisis is happening during a pregnancy, like with preeclampsia? Well, the playbook flips completely. Here, drugs like labetalol or hydralazine are the go-to because they're safe for the fetus. But you have to, and I mean have to, avoid a really common class of meds called ACE inhibitors. They're great in other settings, but they can cause serious birth defects. And on top of that, you're also giving magnesium to prevent seizures. It's a whole different protocol.
And here's one more with a critical sequence, a crisis from a pheochromocytoma. That's a rare tumor that pumps out adrenaline. If you give a beta blocker first, you're blocking the slowdown signal to the heart, but you haven't blocked the squeeze signal to the blood vessels. We call that unopposed alpha stimulation, and it can cause the vessels to clamp down so hard the blood pressure goes even higher. It's catastrophic. You absolutely have to block those alpha receptors first.
So after walking down these two very different roads, what's the big lesson here? It really all boils down to a core philosophy that every good clinician lives by. You have to treat the patient who is sitting in front of you, not just the number that's flashing on the monitor.
And this little checklist is a fantastic way to put it all together. First, you confirm the reading. Make sure it's accurate. Step 2, and this is the most important one, you screen for signs of end organ damage. That's your decision point. That's what tells you if you're dealing with an urgency or an emergency. From there, you set your target, slowly or that controlled 10-20% drop. And finally, you select the right tool for the job, especially if you're in that emergency lane.
And look, if you only take away one thing from all of this, let it be this right here. Unless there is clear, undeniable proof of ongoing organ damage, a gradual reduction in blood pressure is almost always safer than a rapid one. The human body is this amazing machine that adapts to its environment, even a high-pressure one. The key is to respect that adaptation. Guide it back to safety. Don't shock it into a brand new crisis. The real question isn't just how low you can get the number, but how safely you can get there.